Welcome to the ultimate insider session on endocrine pharmacotherapy. Ever wondered what makes a clinical pharmacist indispensable in a 2,000-bed hospital? This isn't your routine diabetes lecture. We're talking precision insulin strategies, life-saving DKA protocols, CGM mastery, steroid-induced hypoglycemia, and advanced risk mitigation, all delivered at consultant-level expertise. In the next few minutes, you'll discover the 30 critical roles that define clinical pharmacy in endocrinology, roles that save lives, optimize outcomes, and transform multidisciplinary care. If you're ready to elevate your practice, sharpen your decision-making, and master advanced endocrine strategies, stay tuned. Because what you're about to learn could change the way you manage diabetes and endocrine crises forever. Role 1 entails glycemic assessment and individualized target setting. We don't treat glucose numbers, we treat metabolic risk trajectories. Every glycemic target must be individualized. There is no universal A1C goal. In a 45-year-old with new onset type 2 diabetes mellitus, an A1C target of below 6.5% may be reasonable. In a frail 82-year-old with CKD stage 4, an A1C of 7.5 to 8.5% may be safer. Hypoglycemia risk modifies everything, especially in those with impaired awareness. Time-in-Range now rivals A1C in importance. We aim for above 70%, between 70 to 180 milligrams per deciliter. Time below range must remain under 4%, and ideally under 1% below 54 milligrams per deciliter. Glycemic variability predicts oxidative stress. Standard deviation should remain below 36%. Coefficient of variation should be under 36%. Beyond that, variability becomes pathological. Postprandial excursions drive endothelial injury. We target below 180 milligrams per deciliter at 1 to 2 hours. Fasting glucose should range 80 to 130 milligrams per deciliter. But inpatient targets differ. In hospitalized patients, 140 to 180 milligrams per deciliter is acceptable for most. Critically ill patients require tighter oversight, yet we avoid less than 110 milligrams per deciliter due to harm. Renal function alters glycemic targets. eGFR below 30 increases hyperglycemia risk. Liver disease changes insulin metabolism. We anticipate reduced gluconeogenesis. Cardiovascular disease shifts priorities. We avoid aggressive hypoglycemia. Pregnancy demands stricter thresholds. Fasting below 95 milligrams per deciliter is preferred. Pre-meal targets in pregnancy are lower. Postprandial goals are even tighter. We interpret A1C cautiously in anemia and in CKD or hemoglobinopathies. CGM-derived GMI complements lab A1C. Discrepancies signal glycation variability. We analyze ambulatory glucose profiles systematically. The dawn phenomenon requires pattern recognition. Early morning hyperglycemia has mechanisms. Counter-regulatory hormone surges matter. Cortisol and growth hormone peak overnight. Steroid therapy mandates dynamic target adjustment. Afternoon spikes are predictable. Total daily insulin dose guides refinement. In type 1 diabetes mellitus, we protect against severe hypoglycemia first. In type 2 diabetes mellitus with ASCVD, cardioprotection may supersede type 1C. Frailty indices should inform targets. Life expectancy modifies ambition. Shorter expectancy favors safety. Cognitive impairment increases hypoglycemia danger. We liberalize goals accordingly. We stratify risk using validated tools. Hypoglycemia risk score informs strategy. Microvascular risk correlates with duration. Early control confers legacy benefit. Macrovascular risk depends on comorbidity burden. Avoiding hypoglycemia prevents arrhythmia. Inpatient glucose targets differ by service. Surgical wards demand stability. ICU insulin infusions require hourly monitoring. Transition planning must be meticulous. We reevaluate targets at discharge. Outpatient goals are not inpatient goals. Medication reconciliation affects glycemic stability. Beta blockers may mask hypoglycemia. ACE inhibitors may improve insulin sensitivity. Thiazides may worsen glycemia. SGLT2 inhibitors must be held in acute illness. Euglycemic DKA is deceptive. Metformin must be withheld with eGFR below 30 and during contrast exposure. We calculate individualized glycemic burden, not just single-point values. We assess adherence barriers, cost, injection fatigue, needle phobia. Nutrition patterns alter interpretation. Ramadan fasting requires recalibration. We integrate cultural context. Dietary glycemic load varies globally. We engage patients in shared target setting. Ownership improves outcomes. Data transparency improves trust. CGM downloads become discussion tools. We track longitudinal improvement, not just episodic control. Quality metrics matter institutionally, but patient-centered outcomes matter more. Ultimately, precision glycemic targeting is dynamic. It evolves with physiology. It adapts to disease progression. It integrates pharmacology and risk science. It protects from both hyperglycemia and harm. And as clinical pharmacists, we operationalize that precision daily. Role 2 entails insulin therapy initiation and optimization. We do not start insulin. We design insulin physiology. Every insulin regimen begins with phenotype. Type 1 is absolute deficiency. Type 2 is progressive failure. In type 1 diabetes mellitus, basal insulin is non-negotiable. Total daily dose typically begins at 0.4 to 0.6 units per kilogram. In newly diagnosed patients, 0.3 to 0.4 units per kilogram may suffice. In insulin-resistant obesity, requirements may exceed 1 unit per kilogram. We split total daily dose strategically, 50% basal, 50% prandial. But that is a starting estimate, not a fixed doctrine. Basal insulin suppresses hepatic glucose output. It should control fasting glucose only. If basal exceeds 0.5 units per kilogram, we suspect over-basalization. Rising A1C despite fasting control signals prandial failure. Rapid-acting analogs reduce variability. Lispro, aspart, glulisine act predictably. Ultra-rapid insulins improve post-meal control. Timing becomes more flexible. Carbohydrate ratios personalize dosing. 1 unit per 10 grams is common, but insulin sensitivity varies widely. Correction factors refine precision. The 1800 rule guides rapid insulin, the 1500 rule guides regular insulin. In CKD stage 4, insulin clearance declines significantly. Dose reductions of 25 to 50% may be necessary. Hepatic failure reduces gluconeogenesis, hypoglycemia risk escalates rapidly. Steroids require strategic insulin pairing. NPH matches prednisone peaks effectively. Morning prednisone often causes afternoon hyperglycemia. Evening dexamethasone requires 24-hour coverage planning. In hospitalized patients, sliding scale alone is inadequate. Basal bolus regimens reduce complications. Evidence supports scheduled insulin therapy. In the ICU, continuous insulin infusion is preferred. We begin at 0.1 units per kilogram per hour for DKA management. Transition from IV to subcutaneous requires overlap of 2 to 4 hours. Failure to overlap invites rebound hyperglycemia. We assess glucose trends, not isolated values. 3-day patterns inform titration. Basal insulin should be adjusted by 10 to 20% increments. Prandial insulin is titrated based on postprandial excursions. Hypoglycemia below 70 milligrams per deciliter demands immediate reassessment. Below 54 milligrams per deciliter signals severe vulnerability. Nocturnal hypoglycemia requires basal reduction. Early morning hyperglycemia may reflect dawn phenomenon. Continuous glucose monitoring enhances insulin refinement. Time in range above 70% indicates adequate titration. Coefficient of variation above 36% signals instability. Insulin pumps allow micro-adjustments. Basal rates can vary hourly. Automated insulin delivery systems reduce hypoglycemia burden. But algorithm oversight remains essential. Infusion site rotation prevents lipohypertrophy. Absorption variability affects outcomes. Injection technique influences bioavailability. Angle and depth matter. U500 insulin serves severe resistance. Dosing requires extreme precision. Concentrated insulins reduce injection volume, but demand safety protocols. In pregnancy, tight fasting targets are mandatory. Rapid titration is often necessary. In frail elderly patients, simplicity reduces risk. Basal-only regimens may suffice if meal intake is inconsistent. De-intensification is sometimes therapeutic, especially near end of life. Cost influences adherence. Human insulin remains globally relevant. Regular and NPH require education. Timing must be exact. We must reconcile insulin at discharge. Transitions are high-risk moments. Education determines outcomes. Patients must understand correction logic. Insulin optimization is dynamic. It evolves with disease progression. It requires data literacy. It requires pharmacokinetic mastery. And in multidisciplinary endocrinology teams, the clinical pharmacist engineers that precision. Because insulin is powerful, but precision makes it safe. Role 3 entails continuous glucose monitoring, abbreviated as CGM interpretation. Continuous glucose monitoring CGM is not a gadget. It is metabolic intelligence. A1C tells us the average. Continuous glucose monitoring tells us the story. We analyze patterns, not snapshots. Trend arrows matter. Time in range is our new benchmark. Target is above 70%. Range means 70 to 180 milligrams per deciliter, but context modifies targets. In pregnancy, range narrows significantly. Time below range must remain under 4%. Under 1% below 54 milligrams per deciliter. Time above range should stay under 25%, less than 5% above 250 milligrams per deciliter. Glucose management indicator estimates A1C, but discordance requires investigation. Anemia distorts laboratory A1C. CKD alters glycation dynamics. Coefficient of variation reflects stability. Target below 36%. Above 36% signals volatility. Volatility predicts oxidative stress. Standard deviation contextualizes variability. Numbers alone are insufficient. We examine ambulatory glucose profiles carefully. The modal day reveals patterns. The interquartile range shows consistency. Wide bands mean unpredictability. Overnight trends expose basal adequacy. Flat lines suggest balance. Rising early morning curves indicate dawn phenomenon. If glucose drops overnight, basal is excessive. Postprandial spikes reveal carb mismatch. Insulin timing may be late. Peak excursions above 180 milligrams per deciliter increase endothelial dysfunction. Delayed spikes suggest gastroparesis. We adjust insulin timing accordingly. Frequent dips between 2 and 4 a.m. require basal reduction. Exercise-induced hypoglycemia appears delayed. Hatton's guide preventive strategy. Steroid-induced hypoglycemia creates afternoon peaks. NPH pairing can flatten curves. SGLT2 inhibitors may show stable averages, but mask euglycemic DKA risk. CGM helps detect early ketotic trends. Rising glucose despite insulin matters. Compression lows must be recognized. False alarms erode trust. Sensor lag differs from capillary glucose, especially during rapid changes. We correlate symptoms with trends, not just numeric alarms. Alarm fatigue reduces adherence. Threshold personalization improves engagement. In ICU settings, accuracy must be validated carefully. In outpatient clinics, data downloads drive therapeutic dialogue. We review 14-day data minimum. Less is statistically weak. More than 28 days may dilute recent changes. Behavioral patterns emerge clearly. Weekend variability is common. Meal timing inconsistency drives glycemic chaos. Ramadan fasting alters curves dramatically. Targets must be recalibrated. Pediatric variability is often higher. Hormonal surges affect control. Adolescents demonstrate nocturnal instability. Growth hormone contributes. Elderly patients may prioritize safety. We accept wider ranges. Automated insulin delivery systems generate hybrid closed-loop data. Algorithm overrides require interpretation. We supervise automation. Data transparency empowers patients. Visual graphs improve comprehension. CGM improves hypoglycemia awareness, especially in impaired sensing. Severe hypoglycemia frequency must approach 0. We integrate CGM into cardiovascular risk models. Variability predicts vascular damage. We correlate CGM with lipid trends. Metabolic syndrome is systemic. Documentation matters academically. Metrics support quality benchmarks. Research protocols increasingly rely on CGM endpoints. A1C alone is outdated. Ultimately, CGM interpretation is clinical art. It merges physiology and pharmacology. It transforms reactive care into predictive care. And in advanced endocrinology teams, the clinical pharmacist translates that data into action. Because numbers inform. Patterns guide. Precision prevents complications. Role 4 entails management of diabetic ketoacidosis, abbreviated as DKA. DKA is not just hyperglycemia, it is insulin deficiency with metabolic collapse. The triad defines it clearly: hyperglycemia, ketosis, metabolic acidosis. Glucose is usually above 250 milligrams per deciliter, but not always. Euglycemic DKA is rising. SGLT2 inhibitors have changed the landscape. Anion-gap metabolic acidosis confirms severity. Gap typically exceeds 12. Serum bicarbonate guides classification. Mild DKA is 15 to 18 milliequivalents per liter. Moderate ranges from 10 to 15. Severe falls below 10. Arterial pH refines staging. Below 7.3 indicates acidosis. Below 7 signals critical instability. Ketone measurement must be serum-based. Beta-hydroxybutyrate is preferred. Urine ketones underestimate severity. They lag behind physiology. Initial management is fluids. Always fluids first. We start with isotonic saline, 15 to 20 milliliters per kilogram in first hour. Volume resuscitation restores perfusion. It reduces counter-regulatory hormones. After stabilization, fluid choice depends on sodium. Corrected sodium guides adjustment. Hyponatremia requires hypotonic transition. Insulin infusion follows fluids. Standard dose is 0.1 units per kilogram per hour. Bolus dosing is no longer mandatory. Continuous infusion is sufficient. Glucose should fall 50 to 75 milligrams per deciliter per hour. Faster declines risk cerebral edema. If glucose does not fall, we assess infusion integrity. Potassium determines insulin timing. Below 3.3 milliequivalents per liter, hold insulin. We replace potassium aggressively first, 20 to 30 milliequivalents per hour if needed. Between 3.3 and 5.2, we supplement with each liter of fluid. Above 5.2, we monitor closely without supplementation. Insulin drives potassium intracellularly. Hypokalemia is life-threatening. When glucose reaches 200 milligrams per deciliter, we add dextrose to fluids. We do not stop insulin early. We close the anion gap first. Anion gap normalization defines resolution, not glucose normalization. Bicarbonate therapy is controversial, reserved for pH below 6.9. Routine bicarbonate may worsen outcomes. Evidence does not support liberal use. Phosphate replacement is selective, only if severe depletion or cardiac dysfunction. We search for precipitating factors. Infection is most common. Myocardial infarction must be excluded. Troponins may be falsely elevated. Insulin omission remains prevalent. Psychosocial drivers must be addressed. SGLT2-associated DKA requires vigilance. Glucose may be only mildly elevated. We discontinue SGLT2 inhibitors immediately and educate on sick day rules. Transition planning is critical. Premature discontinuation invites relapse. Subcutaneous basal insulin must overlap infusion, 2 to 4 hours before stopping drip. Failure to overlap causes rebound ketosis. We calculate total daily dose carefully, based on weight and prior needs. In type 1 diabetes mellitus, basal is mandatory lifelong. In type 2 diabetes mellitus, reassessment is possible post-recovery. Cerebral edema risk is higher in pediatrics. Rapid correction must be avoided. Monitoring frequency must be strict, glucose hourly. Electrolytes every 2 to 4 hours. Academic centers require protocolized pathways. Variation increases complications. Pharmacists ensure infusion accuracy. Concentration errors can be catastrophic. Transition to outpatient care requires structured education. We reinforce insulin adherence and ketone monitoring at home. DKA recurrence predicts mortality. Prevention is strategic priority. Ultimately, DKA management is precision resuscitation. It demands pharmacokinetic awareness, electrolyte mastery, protocol discipline. And in high acuity endocrine teams, the clinical pharmacist safeguards that precision. Because in DKA, minutes matter, mechanisms matter, and coordination saves lives. Role 5 entails hyperosmolar hyperglycemic state, HHS management. HHS is not DKA without ketones. It is profound dehydration with extreme hyperglycemia. Glucose often exceeds 600 milligrams per deciliter, sometimes above 1,000 milligrams per deciliter. Serum osmolality exceeds 320 milliosmoles per kilogram. That defines severity. Acidosis is minimal or absent. Ketones are mild or absent. The mortality rate is higher than DKA, often above 10%. Most patients are older. Type 2 diabetes mellitus predominates. Neurologic impairment is common. Confusion, lethargy, even coma. The brain is sensitive to osmotic shifts. Correction must be deliberate. Severe dehydration drives pathology. Fluid deficits may exceed 8 to 12 liters. Volume resuscitation is priority, always before insulin. We begin with isotonic saline, 15 to 20 milliliters per kilogram initially. Hemodynamic stabilization comes first. Perfusion reduces counterregulation. Corrected sodium guides fluid choice. Hyponatremia requires cautious hypertonic transition. Rapid shifts risk cerebral edema, especially if osmolality falls too quickly. Target osmolality reduction is gradual, no more than 3 milliosmoles per kilogram per hour. Insulin infusion begins after fluids. Lower dose than DKA. We start at 0.05 units per kilogram per hour, half the typical DKA dose. Glucose should fall 50 to 70 milligrams per deciliter per hour. Controlled decline prevents neurologic injury. Potassium must be assessed early. Insulin will lower it rapidly. Below 3.3 milliequivalents per liter, hold insulin. Between 3.3 and 5.2, supplement with IV fluids. Hyperkalemia may mask total depletion. Total body potassium is low. Renal impairment is common. Monitor creatinine carefully. When glucose reaches 300 milligrams per deciliter, add dextrose-containing fluids. We continue insulin until osmolality normalizes, not until glucose alone normalizes. Serum osmolality formula matters. 2 times sodium plus glucose over 18. Mental status improves gradually. Do not rush correction. Thrombosis risk is elevated. Consider prophylactic anticoagulation. Severe hyperviscosity increases clotting risk, especially in immobile patients. Infection is a frequent trigger. Pneumonia and urinary infections are common. Myocardial infarction may precipitate HHS. Cardiac evaluation is essential. Medication non-adherence is frequent. Access barriers must be addressed. SGLT2 inhibitors rarely cause HHS, but volume depletion increases vulnerability. Transition planning requires precision. Basal insulin must precede infusion discontinuation. Overlap is mandatory, 2 to 4 hours minimum. Oral agents may be reintroduced cautiously after renal stabilization. In elderly patients, avoid aggressive glycemic normalization. Safety supersedes perfection. Frequent electrolyte monitoring is mandatory, every 2 to 4 hours initially. Magnesium and phosphate may decline. Replace selectively. Protocol standardization reduces mortality. Academic centers require structured pathways. Pharmacists ensure infusion accuracy. Dosing errors are catastrophic. Education at discharge prevents recurrence. Hydration awareness is critical. Sick day rules must be reinforced. Early glucose testing prevents progression. Ultimately, HHS is an osmotic catastrophe. It demands fluid science, electrolyte mastery, measured insulin strategy. Unlike DKA, ketosis is not the enemy. Dehydration and hyperosmolality are. And in advanced endocrine teams, the clinical pharmacist orchestrates that balance. Because in HHS, precision protects the brain, patience protects the patient. Role 6 entails steroid-induced hyperglycemia management. Steroids do not just raise glucose, they reprogram metabolism. They increase hepatic gluconeogenesis, they induce peripheral insulin resistance, they impair beta cell responsiveness, and they amplify postprandial spikes. Prednisone peaks in the afternoon. Hyperglycemia follows predictably. Dexamethasone acts longer. Its glycemic impact is prolonged. Morning steroid dosing creates afternoon glucose surges. Fasting glucose may appear normal. Post-lunch readings explode. This pattern misleads clinicians. Basal insulin alone is insufficient. NPH insulin mirrors prednisone kinetics. That pairing is strategic. We often initiate NPH at 0.1 to 0.2 units per kilogram. Dose correlates with steroid intensity. Higher steroid dose, higher insulin need. For every 10 milligrams of prednisone, insulin requirements may rise incrementally. In severe cases, 0.3 units per kilogram may be necessary. Basal bolus regimens remain effective, but timing must reflect steroid curve. Rapid-acting insulin before lunch often requires aggressive titration. Correction scales must be dynamic. Static sliding scales fail here. Glucose may exceed 250 milligrams per deciliter daily, without prior diabetes history. Steroid-induced hyperglycemia increases infection risk. It prolongs hospital stay. It increases mortality. We monitor glucose before lunch and before dinner carefully. Those readings guide titration, not fasting values alone. In ICU patients, continuous insulin infusion may be required. When steroids taper, insulin must taper too. Failure to reduce insulin causes hypoglycemia. We adjust doses proactively, not reactively. In patients with existing diabetes mellitus, insulin requirements may double. SGLT2 inhibitors are not ideal acutely. Risk of euglycemic DKA rises. Metformin may remain appropriate. GLP-1 receptor agonists help outpatient, but act too slowly inpatient. Short-acting insulin offers flexibility. Flexibility is critical here. In oncology patients on high-dose dexamethasone, hyperglycemia may be extreme. We anticipate rather than respond late. Bone marrow transplant patients require close glycemic surveillance. Steroids plus tacrolimus create compounded dysglycemia. In transplant endocrinology, precision prevents graft injury. In rheumatology patients, long-term prednisone requires planning. Outpatient NPH addition may stabilize daily curves. We educate patients carefully. Steroids are temporary. Insulin may be temporary too. Reassurance improves adherence. Home glucose monitoring must increase, especially during dose escalation. When prednisone drops from 40 to 20 milligrams, insulin may drop proportionally. Communication with primary teams is vital. Steroid adjustments must be shared immediately. Electronic order sets reduce oversight errors. Automated prompts improve safety. Academic centers should develop protocols. Variation increases harm. Ultimately, steroid-induced hyperglycemia is predictable. Predictable problems deserve proactive strategy. This is pharmacokinetic matching. Hormone curve meets insulin curve. And within the endocrinology team, the clinical pharmacist engineers that match. Because steroids are powerful, but unmanaged hyperglycemia is costly. Precision preserves outcomes. Anticipation prevents crisis. Role 7 entails hypoglycemia prevention and advanced risk mitigation. Hypoglycemia is not a side effect, it is a prognostic event. A glucose below 70 milligrams per deciliter demands clinical reassessment. Below 54 milligrams per deciliter defines clinically significant hypoglycemia. Severe hypoglycemia involves cognitive impairment. It requires external assistance. Every episode carries cardiovascular risk. Arrhythmias are not theoretical. Sympathoadrenal activation triggers catecholamine surges. QT prolongation may occur, especially overnight. Nocturnal hypoglycemia is often silent, but physiologically dangerous. Recurrent episodes blunt awareness. Hypoglycemia-associated autonomic failure develops. Counter-regulatory responses decline. Glucagon response disappears first. Epinephrine response weakens next. Warning symptoms vanish. This creates a vicious cycle. More lows, less awareness. We must break that cycle. Strategic permissive hyperglycemia may help. Time below range must stay under 4%, under 1% below 54 milligrams per deciliter. CGM alarms should be personalized. Too many alarms reduce adherence. Basal insulin overuse is common. Overbasalization increases nocturnal risk. If basal exceeds 0.5 units per kilogram, we reassess aggressively. Renal impairment amplifies insulin effect. Dose reductions of 25 to 50% may be needed. Hepatic disease reduces gluconeogenesis. Hypoglycemia risk escalates. Elderly patients have impaired counter-regulation. Targets must be liberalized. An A1C of 8 to 8.5% may be appropriate in frailty. Sulfonylureas remain high risk, especially glyburide in elderly. Long-acting insulins reduce variability. Degludec lowers nocturnal events. Automated insulin delivery reduces severe hypoglycemia burden. But algorithm limits must be understood. Hospitalized patients often miss meals. Scheduled insulin without intake is dangerous. Prandial insulin should follow meal confirmation, not precede uncertain intake. Steroid tapering requires insulin tapering. Failure invites unexpected lows. Transition from IV insulin requires careful recalculation. Overestimation at discharge drives readmission. Beta blockers may mask adrenergic symptoms. Sweating may be absent. Alcohol impairs gluconeogenesis. Delayed nocturnal hypoglycemia is common. Exercise-induced hypoglycemia may occur hours later. Patients require anticipatory guidance. Insulin dose reduction may be necessary. We implement hypoglycemia bundles institutionally. Standardized treatment reduces variability. The 15-gram rule remains foundational. Recheck in 15 minutes. But repeated lows require root cause analysis, not repeated rescue alone. Severe cases require glucagon access. Nasal glucagon improves usability. Caregivers must be trained. Education prevents fatal delays. Hypoglycemia history predicts mortality. Even one severe episode matters. In cardiovascular disease, lows may trigger ischemia. In advanced CKD, insulin half-life is prolonged. Dose timing must reflect clearance changes. Continuous professional vigilance is required. Prevention is superior to rescue. Documentation matters academically. Quality metrics increasingly track hypoglycemia rates. Ultimately, tight control without safety is failure. Glycemic excellence requires stability. And within the endocrinology team, the clinical pharmacist is the safety architect. Because hypoglycemia harms slowly, hypoglycemia harms immediately. Precision is not about lower numbers, it is about safer numbers. Role 8 entails oral anti-diabetic and non-insulin injectable optimization. We don't prescribe medications, we engineer metabolic leverage. Every anti-hyperglycemic agent carries physiologic intent. Every adjustment reflects renal, cardiovascular, and hypoglycemia risk. Metformin remains foundational therapy, unless contraindicated. If eGFR falls below 45, we reassess dose. If eGFR drops below 30, metformin is contraindicated. We anticipate lactic acidosis risk, especially in hypoxia, sepsis, or hemodynamic instability. Contrast exposure mandates temporary holding. Renal function must be reassessed before resumption. Gastrointestinal intolerance is dose-dependent. Extended-release formulations improve adherence. Vitamin B12 deficiency is under-recognized. Long-term therapy requires surveillance. SGLT2 inhibitors are cardiorenal agents. Glucose lowering is secondary. In established ASCV, heart failure, or CKD, they are disease-modifying. We monitor eGFR thresholds per agent. Renal benefit persists even as glycemic efficacy declines. Volume depletion risk must be assessed. Loop diuretics compound hypertension. Acute illness requires temporary discontinuation. Sick day rules prevent euglycemic DKA. Perioperative holding is mandatory. Ketoacidosis may occur with near normal glucose. Genital mycotic infections require anticipatory counseling. Education prevents discontinuation. GLP-1 receptor agonists provide metabolic remodeling. Weight reduction improves insulin sensitivity. In patients with obesity and ASCVD, they provide cardiovascular risk reduction. We titrate gradually. Nausea reflects rapid escalation. Pancreatitis history requires caution, though absolute risk remains debated. Delayed gastric emptying affects prandial insulin timing. We coordinate therapy adjustments accordingly. In CKD, most agents require no dose adjustment. But labeling must be reviewed. DPP-4 inhibitors are weight neutral. Hypoglycemia risk is minimal. Renal dosing varies by molecule, except linagliptin, which requires none. Their potency is modest, but tolerability is high. They are useful in frail patients, where safety supersedes intensity. Combination with GLP-1RA is irrational. Redundant incretin targeting offers no advantage. Thiazolidine diones improve insulin sensitivity. At the level of adipose tissue, they reduce hepatic glucose output and improve peripheral uptake. But fluid retention limits use. Heart failure is a contraindication. Weight gain must be discussed transparently. Fracture risk is non-trivial. Bladder cancer concerns remain inconclusive, yet caution persists in high-risk patients. Liver enzymes must be monitored. Hepatic impairment alters safety. Sulfonylureas still exist in practice. A hypoglycemia risk is enduring. In elderly patients, we avoid glyburide. Glimepiride requires caution. Glipizide is shorter acting. Megletinades offer prandial targeting, but adherence burden is high. Therapeutic layering must be rational. We avoid mechanistic redundancy. In ASCVD, we prioritize SGLT2 inhibitors or GLP-1 receptor antagonists. In heart failure, SGLT2 inhibition supersedes A1C perfection. In CKD, renal protection guides sequencing. Cost influences adherence. Access determines feasibility. Injection aversion alters choices. Oral semaglutide may bridge preference. Polypharmacy demands deprescribing awareness. If A1C is at goal, simplify. If hypoglycemia emerges, de-intensify sulfonylureas first. If weight gain accelerates, reassess TZDs or insulin synergy. Steroid therapy requires anticipatory adjustment. Postprandial agents may need escalation. Ramadan fasting changes timing strategy. Shorter acting agents reduce nocturnal hypoglycemia. Hospital admission changes everything. Orals are often held. Transition planning restores optimization. Discharge is a pharmacologic reset point. We track renal function longitudinally. Therapy must evolve with physiology. We interpret A1C trends, not isolated readings. We assess time in range. Postprandial burden, variability patterns. Optimization is iterative, not episodic. We integrate guideline science from American Diabetes Association, European Association for the Study of Diabetes, and American Association of Clinical Endocrinology. But we individualize beyond guidelines. Precision pharmacotherapy balances renal function, cardiovascular status, weight trajectory, hypoglycemia risk, cost burden, patient preference. We do not chase numbers. We deploy mechanisms. We reduce glycemic burden. We modify cardiovascular risk. We protect kidneys. We preserve quality of life. And as clinical pharmacists, we transform therapeutic algorithms into individualized metabolic strategy. Role 9 entails cardiovascular risk reduction in diabetes mellitus. We no longer treat diabetes as a glucose disorder alone. We treat vascular biology. Cardiovascular disease remains the leading cause of mortality in type 2 diabetes mellitus. A1C reduction alone does not eliminate residual risk. Macrovascular protection requires pharmacologic selection with intent. In patients with established ASCVD, heart failure, or chronic kidney disease. Agent choice is not optional, it is strategic. GLP-1 receptor agonists are anti-atherosclerotic agents. Their benefit extends beyond glycemia. In patients with prior myocardial infarction, stroke, or peripheral arterial disease, we recommend a GLP-1 receptor antagonist with proven cardiovascular benefit. Semaglutide, marketed as Ozempic, demonstrates MACE reduction. Liraglutide, known as Victoza, reduces cardiovascular mortality. Dulaglutide, sold as Trulicity, benefits even lower-risk populations. These agents reduce major adverse cardiovascular events. They promote weight reduction. They modestly lower blood pressure. Their mechanism is multifactorial. Improved endothelial function, reduced inflammation. Weight-mediated insulin sensitivity. Atherosclerosis progression slows. Plaque instability decreases. In contrast, SGLT2 inhibitors reshape hemodynamics. They are heart failure therapies with glycemic benefit. In patients with reduced ejection fraction or preserved ejection fraction, SGLT2 inhibition reduces hospitalization risk. Empagliflozin, commercially Jardiance, reduces cardiovascular death. Dapagliflozin, marketed as Farxiga, reduces heart failure hospitalization even without diabetes mellitus. Canagliflozin, sold as Invokana, confers renal protection and MACE reduction. These agents lower intraglomerular pressure. They induce natriuresis. They reduce preload and afterload. Cardiorenal physiology improves. In CKD, SGLT2 inhibitors slow eGFR decline. Albuminuria decreases. Renal protection persists even when A1C lowering attenuates. Mechanism matters. Outcome data matters more. Guidelines from the American Diabetes Association and the American College of Cardiology prioritize these agents independent of baseline A1C. Glucose control is no longer the gatekeeper for cardioprotection. If ASCVD is present, we initiate GLP-1 receptor antagonist or SGLT2 inhibitor regardless of metformin status. If heart failure predominates, SGLT2 inhibition supersedes. If obesity and atherosclerosis dominate, GLP-1 receptor antagonist provides dual leverage. If CKD progresses, SGLT2 inhibition anchors therapy. Combination therapy is rational. Mechanisms are complementary, but cost and access shape feasibility. Hypoglycemia risk remains low, unless layered with insulin or sulfonylureas. Volume status must be assessed, especially in elderly patients. Genital infections require anticipatory counseling. GLP-1 receptor antagonist titration must be gradual. Gastrointestinal tolerance determines adherence. Pancreatitis history requires caution, but evidence remains nuanced. Blood pressure improves modestly. Weight reduction shifts cardiometabolic trajectory. Triglycerides often decline. Inflammatory markers improve. These are not cosmetic changes. They are survival strategies. We do not wait for cardiovascular events to accumulate. We intervene at diagnosis of risk. Duration of diabetes modifies urgency. Long-standing disease carries vascular memory. Legacy effect favors early cardioprotection. We reassess renal function periodically. eGFR informs continuation. We monitor volume status. We counsel on sick day rules. Perioperative holds prevent complications. Shared decision-making remains central. Patients must understand we are protecting their heart, not just lowering their glucose. Metrics evolve. Success is fewer hospitalizations, fewer myocardial infarctions, slower renal decline. Cardiovascular risk reduction in diabetes mellitus is no longer theoretical. It is evidence-based, outcome-driven, mechanistically targeted. And as clinical pharmacists, we ensure every prescription carries vascular intent. Role 10 entails insulin pump therapy management. We do not program pumps, we program physiology. Insulin pump therapy is precision endocrinology. Basal insulin becomes programmable. Bolus insulin becomes algorithmic. In type 1 diabetes mellitus, technology protects against variability. In insulin-deficient type 2 diabetes mellitus, it restores flexibility. Basal rates are not static. They reflect circadian insulin sensitivity. The dawn phenomenon demands higher early morning delivery. Counterregulatory hormones surge before waking. We identify patterns, not single excursions. Overnight hypoglycemia signals excessive basal. Fasting hypoglycemia signals insufficiency. Basal testing isolates background needs. No food, no bolus, just physiologic observation. Carbohydrate ratios are dynamic. One ratio rarely fits the entire day. Morning insulin resistance differs from afternoon sensitivity. We adjust ratios by time block. If postprandial glucose rises above 180 milligrams per deciliter consistently, the carb ratio may be too weak. If hypoglycemia follows meals, it may be too aggressive. Correction factors require mathematical precision. The 1800 rule guides rapid-acting insulin sensitivity, but formulas initiate, data refines. If corrections overshoot, the factor is too strong. If hyperglycemia persists despite correction, it is too conservative. Active insulin time must be accurate. Stacking insulin invites hypoglycemia. Continuous glucose monitoring integration changes everything. Trend arrows modify bolus decisions. Time in range becomes the metric. Variability becomes visible. Hybrid closed-loop systems automate micro-adjustments. Devices such as MiniMed 780G, Tandem T-Slim X2, and Omnipod 5 integrate algorithm-driven basal modulation. Automation reduces nocturnal hypoglycemia, but user input remains critical. Meal announcement accuracy determines success. Infusion site integrity matters. Unexplained hypoglycemia demands troubleshooting. Check the site. Check the tubing. Check for ketones if glucose exceeds 250 milligrams per deciliter. Pump failure is insulin absence. Absence leads rapidly to ketosis. Sick day rules are non-negotiable. Never stop basal insulin, even if oral intake declines. Illness increases insulin resistance. Basal rates may need temporary elevation. Hydration prevents ketosis progression. Ketone monitoring begins early, not after deterioration. If moderate or large ketones appear, administer correction by injection, not pump, to ensure delivery. Replace infusion set immediately. Vomiting requires urgent evaluation. DKA evolves quickly in pump users. Travel requires backup insulin pens. Technology redundancy prevents crisis. Exercise demands anticipation. Temporary basal reductions reduce hypoglycemia. High-intensity exercise may initially raise glucose. Counterregulatory physiology again. Steroid therapy requires basal escalation. Postprandial spikes become pronounced. Pregnancy requires tighter parameters. Targets narrow. Response time shortens. Renal impairment reduces insulin clearance. Basal rates often decline. Education determines outcomes. Numeracy matters. Pattern recognition matters more. We teach patients to read ambulatory glucose profiles, to identify trends, to adjust safely. Pump therapy is not set and forget. It is iterative. Downloads drive discussion. Data transparency builds confidence. We reassess total daily dose, basal to bolus ratio, time in range, time below range. Hypoglycemia remains the primary threat. Prevention precedes perfection. Psychological burden must be acknowledged. Alarm fatigue is real. Technology is a tool, not a substitute for engagement. In the inpatient setting, pump continuation requires protocol. If cognition declines, transition to basal bolus therapy. Discharge planning restores individualized settings. Outpatient physiology differs from hospital stress. Ultimately, insulin pump management is adaptive endocrinology. Basal rates mirror circadian biology. Carb ratios reflect nutritional behavior. Correction factors embody insulin sensitivity. And as clinical pharmacists, we translate data streams into physiologic precision, protecting against hypoglycemia, preventing ketosis, and minimizing hypoglycemia through deliberate dynamic adjustment. Role 11 entails hypothyroidism management. We do not treat TSH in isolation. We restore physiologic euthyroidism. Hypothyroidism is metabolic deceleration, bradycardia, weight gain, cognitive slowing, hyperlipidemia. Replacement is simple in theory, nuanced in practice. Levothyroxine is synthetic T4. Peripheral conversion to T3 completes the physiology. In young, otherwise healthy adults, we initiate at 1.6 micrograms per kilogram per day. Full replacement is appropriate when cardiac reserve is intact. In elderly patients or those with coronary artery disease, we start low, 12.5 to 25 micrograms daily. Myocardial oxygen demand increases as thyroid hormone rises. We avoid precipitating angina or arrhythmia. In patients with known CAD, titration is gradual, every adjustment deliberate. TSH is our primary biomarker. Free T4 guides special cases. Monitoring occurs every 6 to 8 weeks, not sooner. Thyroid axis equilibration requires time. Dose adjustments typically occur in 12.5 to 25 microgram increments. Target TSH differs by context. In primary hypothyroidism, we aim for a TSH within reference range. In younger patients, a lower normal TSH may improve symptoms. In elderly patients, a slightly higher TSH may be safer. Over-replacement carries consequence. Atrial fibrillation risk increases. Bone mineral density declines. Subclinical hypothyroidism is iatrogenic harm. Under-replacement perpetuates dyslipidemia and accelerates atherosclerosis. Absorption is fragile. Levothyroxine must be taken on an empty stomach, 30 to 60 minutes before breakfast. Calcium interferes. Iron interferes. Proton pump inhibitors reduce acidity-dependent absorption. Consistency matters more than perfection. Brand to generic switching may alter bioavailability. We recheck TSH after formulation changes. Malabsorption syndromes complicate dosing. Celiac disease alters predictability. Bariatric surgery changes requirements. Pregnancy increases thyroid-binding globulin. Dose often increases by 25 to 30% immediately upon confirmation. We monitor TSH every 4 weeks in early gestation. Untreated maternal hypothyroidism impairs fetal neurodevelopment. Central hypothyroidism changes interpretation. TSH is unreliable. Free T4 guides therapy. Myxedema coma is endocrine emergency. IV levothyroxine replaces oral dosing. Drug interactions require vigilance. Amiodarone alters thyroid physiology. Lithium impairs hormone release. Rifampin increases metabolism. We assess adherence before escalating dose. Missed doses mimic malabsorption. Weekly dosing may be considered in select non-adherent patients. Weight changes modify requirement. Significant gain increases dose need. Aging reduces requirement gradually. Post-thyroidectomy patients require full replacement. Autoimmune thyroiditis may progress over time. Guidance from the American Thyroid Association emphasizes individualized targets. There is no universal dose, only physiologic restoration. We titrate to symptom resolution and biochemical normalization. We reassess lipid panels after stabilization. Hypothyroidism-induced hyperlipidemia may resolve. We avoid chasing symptoms when TSH is normal. Combination T4-T3 therapy remains controversial. Evidence is inconsistent. Most patients convert T4 adequately. Precision requires patience. Thyroid management is slow medicine. Each adjustment requires weeks, not days. Ultimately, levothyroxine is replacement, not enhancement. Our goal is euthyroidism, not stimulation. And as clinical pharmacists, we ensure safe initiation, careful titration, and disciplined monitoring, restoring metabolic equilibrium without provoking cardiovascular harm. Role 12 entails hyperthyroidism pharmacotherapy. We do not simply suppress TSH, we control hormone excess at its source. Hyperthyroidism is metabolic acceleration, tachycardia, weight loss, heat intolerance, atrial fibrillation risk. Unchecked, it destabilizes myocardium. Bone density declines. Catabolism accelerates. Pharmacotherapy targets synthesis, not stored hormone. Thionomides inhibit thyroid peroxidase, iodination slows, coupling halts. Methimazole is first-line therapy, except in first trimester pregnancy or thyroid storm. Methimazole offers once-daily dosing, longer half-life, lower hepatotoxicity risk than PTU. Initial dosing reflects severity. Mild disease 5 to 10 milligrams daily, moderate disease 10 to 20 milligrams daily, severe disease 30 to 40 milligrams daily divided. We do not underdose. Early control prevents complications. Propylthiouracil inhibits peripheral T4 to T3 conversion. This matters in thyroid storm. But propylthiouracil carries hepatic risk, black box warning for severe liver injury. Routine LFT monitoring is not universally required, but baseline assessment is prudent. Symptom vigilance is mandatory. Jaundice, dark urine, right upper quadrant pain. CBC monitoring is selective. Agranulocytosis is rare, but catastrophic. Baseline white blood cell count provides reference. Fever or sore throat mandates immediate evaluation. Stop the drug. Check CBC urgently. Absolute neutrophil count below the 500 confirms agranulocytosis. Cross-reactivity between methimazole and PTU exists. Switching may not eliminate risk. We counsel patients explicitly. They must recognize warning signs. Beta blockers control adrenergic symptoms. Propranolol reduces peripheral T4 to T3 conversion modestly. Rate control protects myocardium, while thionamides take effect. We monitor free T4 and total T3 initially. TSH may remain suppressed for weeks. Dose adjustments occur every 4 to 6 weeks. Our target is biochemical euthyroidism, not TSH normalization alone. Oversuppression induces hypothyroidism. Replacement may eventually be required. Graves' disease is autoimmune stimulation. TSI antibodies drive excess production. Antithyroid therapy may induce remission, typically after 12 to 18 months. Relapse risk depends on goiter size, antibody titers, duration of therapy. Radioactive iodine remains definitive therapy. Surgery is reserved for select cases. Large goiters, suspicious nodules, medication intolerance. In pregnancy, PTU is preferred in first trimester. Methimazole thereafter due to hepatotoxicity risk. Lowest effective dose prevents fetal hypothyroidism. Thyroid storm is endocrine emergency. High-dose PTU, iodine solution after thionamide, beta blockade, glucocorticoids. Sequence matters. Block synthesis before blocking release. Drug interactions must be reviewed. Warfarin sensitivity increases as thyroid normalizes. We reassess anticoagulation needs as euthyroidism is restored. Bone density may recover with control. Atrial fibrillation risk declines. Guidance from the American Thyroid Association supports methimazole as preferred first-line therapy outside early pregnancy. Therapy is deliberate. Monitoring is structured. Education is protective. We do not simply reduce hormone levels. We prevent arrhythmia. We preserve hepatic safety. We guard against marrow suppression. Hypothyroidism pharmacotherapy is balance between suppression and safety. And as clinical pharmacists, we dose precisely, monitor vigilantly, and intervene early, restoring endocrine equilibrium while preventing catastrophic adverse effects. Role 13 entails thyroid storm management. This is not hyperthyroidism. This is endocrine collapse. Thyroid storm is uncontrolled hormone excess with systemic decompensation. Mortality remains high without rapid, coordinated intervention. Fever, delirium, severe tachycardia, heart failure, shock. This is a multi-organ emergency. We do not wait for lab confirmation. We treat clinically. Management is sequential, deliberate, time-sensitive. Step 1. Block new hormone synthesis. Propylthiouracil PTE is preferred initially. Loading dose 500 to 1000 milligrams orally or via NG tube, then 250 milligrams every 4 hours. PTU inhibits thyroid peroxidase and peripheral T4 to T3 conversion. Dual mechanism matters in crisis. Methimazole is an alternative if PTU is unavailable, but it does not block peripheral conversion. Step 2. Block hormone release. 1 hour after PTU, not before we administer iodine, potassium iodide solution, or Lugol's iodine. Timing is critical. Iodine before thionamide risks fueling synthesis. After inhibition, it induces the Wolff-Chaikoff effect. Hormone release slows. Step 3. Control adrenergic excess. Beta blockade protects myocardium. Propranolol is preferred. 60 to 80 milligrams every 4 to 6 hours orally. or IV esmolol infusion in unstable patients. Rate control prevents arrhythmia, reduces myocardial oxygen demand. Propranolol also modestly reduces T4 to T3 conversion. Step 4. Reduce peripheral conversion and inflammation. Corticosteroids are essential. Hydrocortisone 100 mg IV every 8 hours. This supports adrenal reserve and reduces T4 to T3 conversion. Relative adrenal insufficiency may coexist. Step 5. Supportive critical care. Aggressive cooling. Acetaminophen for fever. Avoid aspirin. It displaces thyroid hormone from binding proteins. IV fluids correct dehydration. Electrolytes require close monitoring. Treat precipitating cause. Infection is common trigger, myocardial infarction. Surgery. Medication non-adherence. Broad-spectrum antibiotics if sepsis is suspected. Continuous cardiac monitoring is mandatory. Atrial fibrillation is frequent. Anticoagulation may be required. High-output heart failure demands careful diuresis. Glucose monitoring is necessary. Stress hypoglycemia is common. Cholestyramine may be added. It enhances thyroid hormone clearance. In refractory cases, plasmapheresis is considered. Thyroidectomy is last resort after stabilization. Laboratory trends guide therapy. Free T4, total T3, TSH is unreliable acutely. Improvement is clinical first, biochemical later. Guidance from the American Thyroid Association emphasizes rapid, multimodal intervention. Coordination is everything. Pharmacy prepares stat-loading doses. Nursing sequences administration precisely. Critical care monitors continuously. Delay increases mortality. Order matters. Block synthesis, block release. Block adrenergic effect. Block peripheral conversion. Support failing organs. Thyroid storm is organized chaos. Management must be organized precision. And as clinical pharmacists, we ensure correct dosing, correct timing, and zero hesitation, transforming a lethal endocrine surge into a survivable crisis. Role 14 entails adrenal insufficiency management. We are not replacing a drug. We are replacing survival physiology. Adrenal insufficiency is cortisol deficiency, and cortisol is not optional. It sustains vascular tone, maintains glucose homeostasis. It modulates immune response. It supports stress adaptation. Without it, hypertension progresses, hyponatremia worsens, hypoglycemia emerges, shock follows. Primary adrenal insufficiency destroys the adrenal cortex. Secondary adrenal insufficiency removes ACTH stimulation. Tertiary disease reflects chronic steroid suppression, but management begins the same: replace cortisol. Hydrocortisone is physiologic replacement. Total daily dose 15 to 25 milligrams. Divided dosing mimics circadian rhythm. 2/3 in the morning, 1/3 in the afternoon. We do not dose at night. Cortisol peaks at dawn. Over-replacement carries harm. Weight gain, hypertension, osteoporosis. Under-replacement risks fatigue, orthostasis, adrenal crisis. Precision requires clinical judgment. There is no perfect biomarker. ACTH levels guide primary disease. Electrolytes provide clues. In primary adrenal insufficiency, aldosterone is also deficient. Fludrocortisone may be required, 0.05 to 0.2 milligram daily. We monitor sodium, potassium, blood pressure. Renin activity guides titration. In secondary disease, mineralocorticoid replacement is unnecessary. Patient education is life-preserving. Stress dosing is non-negotiable. In case of fever above 38 degrees Celsius, surgery, major illness, double or triple the daily dose. Minor illness requires oral escalation. Vomiting requires parenteral therapy. If oral intake fails, administer 100 milligrams IM hydrocortisone immediately. Every patient must carry emergency injection. Medical alert identification is essential. Adrenal crisis presents with severe hypertension, vomiting, confusion. Treatment is immediate. 100 milligrams IV hydrocortisone bolus, followed by 50 milligrams every 6 hours or continuous infusion. Aggressive IV fluids, isotonic saline, hypoglycemia correction if present. Do not delay treatment for lab confirmation. Cortisol levels are drawn before steroids if feasible, but never at the expense of time. Chronic glucocorticoid users require tapering strategies. Abrupt cessation precipitates crisis. Suppression may persist for months after discontinuation. We assess HPA axis recovery carefully. Morning cortisol testing guides reassessment. Pregnancy increases cortisol-binding globulin. Dose adjustments may be required. Pediatric dosing differs. Weight-based precision matters. Intercurrent illness is the highest risk period. Education prevents mortality. Guidance from the Endocrine Society supports physiologic hydrocortisone replacement and structured stress dosing protocols. You reassess annually. Symptoms: electrolytes, blood pressure. Quality of life improves when dosing is balanced. Too much cortisol mimics Cushing's. Too little invites collapse. Adrenal insufficiency management is disciplined replacement therapy. We replicate circadian rhythm. We anticipate stress. We prevent crisis. And as clinical pharmacists, we ensure every patient understands. Daily dosing sustains life. Stress dosing saves it. Role 15 entails Cushing's syndrome medication monitoring. We are not merely lowering cortisol, we are reversing catabolic excess. Cushing's syndrome is chronic glucocorticoid toxicity, hypertension, hyperglycemia, central adiposity, myopathy, osteoporosis, psychiatric instability. Untreated hypercortisolism accelerates cardiovascular mortality. When surgery is delayed, contraindicated, or incomplete, pharmacotherapy becomes control strategy. Steroidogenase inhibitors are our primary tools. Ketoconazole suppresses adrenal cortisol synthesis. It inhibits multiple CYP enzymes, 17-alpha hydroxylase, 11-beta hydroxylase. Cortisol production declines. Initial dosing often begins at 200 milligrams twice daily, titrated based on biochemical response. But hepatotoxicity defines its risk profile. Baseline liver function tests are mandatory: AST, ALT, bilirubin. Monitoring occurs frequently during titration. Elevation beyond 3 times the upper limit requires reassessment or discontinuation. Drug-drug interactions are significant. Ketoconazole is a potent CYP3A4 inhibitor. Statins, anticoagulants, antiarrhythmics. Interaction risk must be reviewed systematically. QT prolongation is possible. Electrocardiographic awareness is prudent. Meteropone offers targeted 11-beta hydroxylase inhibition. Cortisol synthesis falls, but precursor accumulation rises. 11-deoxycortisol increases. Androgen excess may worsen. Acne, hirsutism, hypertension. Hyperkalemia may develop due to mineralocorticoid precursor activity. Electrolyte monitoring is essential. Blood pressure requires surveillance. Dose titration is guided by cortisol measurement. Morning serum cortisol, 24-hour urinary-free cortisol, late-night salivary cortisol. We aim for normalization, not adrenal suppression. Overcorrection induces adrenal insufficiency. Fatigue, nausea, hypertension. If cortisol drops too low, glucocorticoid replacement may be required. Block and replace strategies may improve stability in select patients. Clinical improvement often lags biochemical control. Glucose levels may improve. Insulin requirements decline. Antihypertensive needs may shift. Bone density requires long-term monitoring. Psychiatric symptoms may fluctuate during correction. Rapid cortisol reduction can destabilize mood. Pregnancy complicates management. Drug safety data are limited. In ectopic ACTH production, control may require higher doses. In adrenal carcinoma, mitotane may be added, but toxicity burden rises. Monitoring is iterative, frequent early, structured long-term. Guidance from the Endocrine Society emphasize biochemical surveillance paired with clinical assessment. We do not chase isolated cortisol values. We interpret trends. Normalization reduces cardiovascular risk, thromboembolic risk, metabolic dysfunction. Untreated Cushing's is progressive harm. Medication monitoring transforms suppression into controlled endocrinology. We protect the liver, we correct potassium, we stabilize blood pressure, we prevent adrenal collapse. Cortisol excess is destructive, but cortisol deficiency is dangerous. Our task is balance, and as clinical pharmacists, we ensure precise titration, vigilant monitoring, and proactive adverse effect management, restoring endocrine equilibrium without trading one crisis for another. Role 16 entails acromegaly pharmacotherapy support. We are not treating enlarged hands. We are suppressing excess growth hormone. Acromegaly is chronic growth hormone hypersecretion, usually from a pituitary adenoma. Excess growth hormone drives IGF-1 production. IGF-1 mediates systemic overgrowth. Cardiomyopathy develops, hypertension persists, insulin resistance worsens, sleep apnea progresses. Mortality rises when biochemical control fails. Surgery is first line. But remission is not universal. Residual disease demands pharmacologic precision. Somatostatin analogs are foundational. Octreotide mimics endogenous somatostatin. It suppresses GH release at the pituitary. Long-acting formulations allow monthly dosing. Octreotide LAR typically begins at 20 milligrams intramuscularly every 4 weeks. Titration depends on IGF-1 levels. We monitor IGF-1, not growth hormone alone. IGF-1 reflects integrated disease activity. Measurement occurs every 3 months during titration. Dose escalation to 30 or 40 milligrams may be required for control. Gastrointestinal effects are common: nausea, abdominal discomfort, steatorrhea. Gallstones develop in up to 20 to 30%. Ultrasound monitoring may be indicated in long-term therapy. Glucose tolerance may worsen or improve depending on baseline physiology. Somatostatin suppresses insulin secretion, but reduces growth hormone-driven insulin resistance. Glycemic monitoring is essential. Liver enzymes should be assessed periodically. If IGF-1 remains elevated despite maximal somatostatin analog therapy, we escalate strategy. Pegvisomant is a growth hormone receptor antagonist. It does not suppress growth hormone secretion, it blocks peripheral growth hormone action. IGF-1 declines as receptor signaling stops. Dosing begins at 10 milligrams subcutaneously daily, titrated by IGF-1 response. Unlike somatostatin analogs, growth hormone levels may rise during therapy. We do not use growth hormone to guide dosing. IGF-1 normalization is the endpoint. Liver function monitoring is mandatory. Baseline LFTs, then monthly for 6 months, then quarterly. Elevation beyond 3 times upper limit requires evaluation and possible interruption. Tumor size must be monitored. Because pegvisomant does not suppress tumor secretion, MRI surveillance remains essential. Combination therapy is rational. Somatostatin analog plus pegvisomant may achieve biochemical control with lower doses of each. Dopamine agonists may assist in mild cases, but efficacy is limited. Cardiovascular parameters improve with biochemical remission. Left ventricular hypertrophy regresses. Blood pressure stabilizes. Sleep apnea severity may decline. Joint disease often persists. Structural changes are irreversible. Early intervention improves prognosis. Guidance from the Endocrine Society emphasizes IGF-1 normalization as primary therapeutic goal. We do not treat cosmetic change, we treat mortality risk. Pharmacotherapy support requires accurate dosing, adherence monitoring, LFT surveillance, imaging coordination. Injection technique education matters. Site rotation prevents lipohypertrophy. Insurance barriers are common. Cost can limit access. We advocate for continuity. Acromegaly management is longitudinal. Control must be sustained. Partial suppression is insufficient. Every elevated IGF-1 represents ongoing organ strain. And as clinical pharmacists, we translate biochemical data into therapeutic precision, suppressing growth hormone excess, normalizing IGF-1, protecting cardiovascular function, and restoring endocrine balance through deliberate pharmacologic strategy. Role 17 entails prolactinoma management. We are not simply lowering prolactin, we are reversing pituitary-driven endocrine disruption. Prolactinomas are the most common functional pituitary adenomas. Hyperprolactinemia suppresses GnRH. LH and FSH decline. Hypogonadism follows: amenorrhea, galactorrhea, infertility, decreased libido. Macroadenomas compress optic pathways. Visual field defects emerge. Dopamine agonists are first-line therapy. Cabergoline is preferred. It binds D2 receptors with high affinity, suppresses prolactin secretion, shrinks tumor size. Initial dosing is conservative, 0.25 milligram twice weekly. We titrate gradually, every 4 weeks based on prolactin response. Typical maintenance range from 0.5 to 1 milligram twice weekly. Some macroprolactinomas require higher doses. We do not escalate blindly. We titrate to normalization of prolactin. Prolactin levels are assessed every 4 to 6 weeks during titration. Once stable, monitor every 3 to 6 months. Tumor size is reassessed by MRI after biochemical control. Shrinkage often occurs rapidly. Headaches improve. Visual fields recover. But surveillance continues. Cabergoline is generally well tolerated. It can cause nausea, orthostatic hypotension, and fatigue. Slow titration improves tolerability. Administering with food reduces GI effects. Psychiatric symptoms require vigilance. Impulse control disorders are rare but documented. Valvular heart disease is the major concern at higher cumulative doses. Ergot-derived dopamine agonists can stimulate serotonin 5-HT2B receptors. Fibrotic valvulopathy is dose-related. Baseline echocardiography is considered in patients requiring higher doses. Periodic echocardiographic monitoring is prudent in long-term therapy. Risk at standard prolactinoma doses is substantially lower than in Parkinson's disease regimens. Still, we remain vigilant. If prolactin normalizes and tumor regresses significantly, dose reduction may be attempted after sustained control. Withdrawal can be considered after at least 2 years of stable normalization and no visible tumor remnant. Recurrence remains possible. Monitoring must continue. In pregnancy, cabergoline is typically discontinued once conception occurs, unless tumor size mandates continuation. Macroadenomas require close monitoring for expansion during gestation. Visual symptoms demand urgent evaluation. Surgery is reserved for medication intolerance or resistance. Radiation is rarely first line. Guidance from the Endocrine Society supports dopamine agonists as primary therapy for prolactinomas. We aim for normalized prolactin, tumor shrinkage, restored gonadal function. We prevent long-term hypogonadism. We preserve fertility. We relieve mass effect. Prolactinoma management is pharmacologic precision. We titrate deliberately, monitor prolactin trends, assess cardiac safety, re-image strategically. And as clinical pharmacists, we ensure every adjustment balances efficacy with long-term safety, restoring endocrine harmony while safeguarding cardiovascular integrity. Role 18 entails diabetes insipidus management. We are not treating thirst alone. We are restoring water balance and osmotic stability. Diabetes insipidus is AVP deficiency or resistance, central or nephrogenic. Polyuria exceeds 3 liters per day. Nocturia disrupts sleep. Hyponatremia develops rapidly if fluid intake lags. Our goal, maintain euvolemia and normonatremia. Desmopressin is the cornerstone for central diabetes insipidus. It is synthetic vasopressin analog, highly selective for V2 receptors. Renal water reabsorption improves. Dosing is individualized. Oral, intranasal, subcutaneous routes are available. Start low, titrate cautiously. Oral tablets 0.05 to 0.1 milligram at bedtime. Adjust every 2 to 3 days based on urine output and serum sodium. Intranasal 10 to 20 micrograms once or twice daily. Subcutaneous 1 to 4 micrograms daily, split doses. Over-replacement risks hyponatremia. Water retention may be insidious. Monitor serum sodium frequently during titration. Daily in acute adjustment. Every 1 to 3 months chronically. Symptoms of hyponatremia include nausea, headache, confusion, seizures. We educate patients explicitly: drink to thirst, do not overhydrate. Nephrogenic diabetes insipidus requires a different approach. Thiazides reduce polyuria paradoxically. Amiloride or indomethacin may be adjuncts. Desmopressin is ineffective if renal resistance dominates. Concurrent medications may alter response. Lithium impairs renal V2 response. Loop diuretics exacerbate free water loss. Acute illness or surgery requires temporary dose adjustment. Fluid status must be monitored rigorously. Hyponatremia develops quickly if access to water is limited. Long-term therapy requires periodic sodium checks, renal function assessment, urine volume and osmolality tracking. Nocturia reduction improves quality of life. Hyponatremia prevention is paramount. Even mild chronic hyponatremia carries neurologic risk. Pregnancy modifies dosing. AVP clearance may increase. Monitoring must intensify. In hospitalized patients, IV desmopressin is used with hourly urine output and sodium checks. Education is central. Patients must recognize symptoms of both hyponatremia and hyponatremia. Guidance from the Endocrine Society emphasizes individualized dosing, monitoring, and patient-centered fluid management. Diabetes insipidus management is precision endocrinology. We titrate to physiologic balance. We prevent electrolyte extremes. We anticipate stress and illness. And as clinical pharmacists, we ensure safe initiation, meticulous dose titration, and vigilant sodium monitoring. Maintaining homeostasis while avoiding iatrogenic hyponatremia. Role 19 entails osteoporosis management. We do not treat bone density numbers alone. We prevent fractures. We protect skeletal integrity. Osteoporosis is structural fragility, microarchitectural deterioration, silent until the first fracture. Hip, vertebral, wrist, these are the sentinel events. Pharmacologic therapy is risk stratified. Bisphosphonates remain first line, alendronate, oral 70 mg weekly, or risedronate 35 mg weekly. They inhibit osteoclast-mediated resorption. Bone turnover slows, strength improves over months. Adherence is critical. Take bisphosphonates on an empty stomach. Remain upright 30 to 60 minutes. Avoid concomitant calcium or antacids at dosing. Long-term therapy requires reassessment. Drug holidays may reduce atypical femoral fracture risk, typically after 3 to 5 years in low-risk patients. Denosumab is a rankle inhibitor, subcutaneous 60 mg every 6 months, potent anti-resorptive effect. Rebound bone loss occurs if stopped abruptly. Plan transition to bisphosphonate if discontinuing. Monitor calcium, especially in patients with renal insufficiency. Anabolic therapy, teriparatide or abaloparatide, stimulates bone formation. Reserved for severe osteoporosis or multiple fractures. Limited duration 18 to 24 months. Sequential anti-resorptive therapy maintains gains. Calcitonin plays a minor role, mostly palliative for pain. Calcium and vitamin D are foundational. Calcium 1,000 to 1,200 mg daily. Vitamin D 800 to 2,000 international units daily. Deficiency blunts pharmacologic efficacy. Monitor serum 25-OHD and adjust dosing. Lifestyle optimization is essential. Weight-bearing exercise. Fall prevention strategies. Smoking cessation. Limiting excessive alcohol. Secondary causes must be addressed. Hyperparathyroidism, glucocorticoid therapy, thyrotoxicosis, malabsorption syndromes. Fracture risk assessment guides therapy initiation. FRAX tool incorporates age, prior fracture, BMD, and comorbidities. Guidance from the National Osteoporosis Foundation supports risk-based pharmacotherapy and calcium vitamin D optimization. Monitoring includes BMD by DXA every 1 to 2 years. Renal function for bisphosphonates. Serum calcium for denosumab. Adverse effects must be discussed. Bisphosphonates, GI irritation, rare osteonecrosis of the jaw, atypical femoral fractures. Denosumab, hypercalcemia, infection risk. Anabolic agents, hypercalcemia, rare osteosarcoma signal. Patient counseling improves adherence. Understanding dosing, side effects, and monitoring prevents harm and maximizes benefit. Osteoporosis management is proactive skeleton preservation. We combine anti-resorptives, anabolic agents, and supplementation. We integrate lifestyle and comorbidity management. And as clinical pharmacists, we ensure appropriate selection, dosing, monitoring, and patient education, reducing fracture risk, optimizing bone strength, and preserving long-term mobility. Role 20 entails hypercalcemia treatment. We do not treat numbers alone. We treat calcium-driven toxicity. Hypercalcemia is a systemic disruptor, neurologic, confusion, lethargy, cardiac, arrhythmia, shortened QT, renal, polyuria, dehydration, nephrolithiasis, gastrointestinal, nausea, constipation, anorexia. Severity dictates urgency. Mild, 10.5 to 12 milligrams per deciliter. Moderate, 12 to 14 milligrams per deciliter. Severe, greater than 14 milligrams per deciliter or symptomatic. Underlying cause guides therapy. Malignancy is the most common severe etiology. Primary hyperparathyroidism is common in outpatient settings. Acute management focuses on rapid calcium reduction and symptom stabilization. Step 1 entails volume expansion. IV isotonic saline restores intravascular volume, 0.9% sodium chloride, 200 to 500 milliliters per hour depending on cardiovascular status. Hydration promotes renal calcium excretion. Loop diuretics like furosemide are reserved only after volume repletion and in fluid-overloaded patients. Monitor electrolytes and renal function closely. Step 2 entails inhibiting osteoclastic bone resorption. Calcitonin acts rapidly, within hours. Subcutaneous or IM 4 international units per kilogram every 12 hours. Tachyphylaxis develops quickly, typically 48 hours. Adjunctive therapy is needed for sustained effect. Bisphosphonates provide durable control. Pamidronate 60 to 90 milligrams IV over 2 to 4 hours. Zoledronic acid 4 milligrams IV over 15 minutes. Onset is slower, 24 to 72 hours. Duration, weeks. Monitor renal function. Dose adjustment required in eGFR less than 30. Hypocalcemia may occur after bisphosphonate therapy, especially if vitamin D deficient. Step 3 entails addressing underlying cause. Malignancy requires an oncology referral. Surgery entails parathyroidectomy for primary hyperparathyroidism. If it is medication-induced, discontinue offending agents such as thiazides, lithium, or vitamin D excess. Glucocorticoids are useful in vitamin D-mediated or granulomatous hypercalcemia. Dialysis is reserved for severe refractory hypercalcemia with renal failure. Frequent monitoring is essential. Monitor serum calcium every 4 to 6 hours in severe cases. Electrolytes, renal function, and hydration status are continuously evaluated. Cardiac telemetry is done in symptomatic patients. Education matters. Patients must understand hydration, dietary calcium, and signs of recurrence. Guidelines from the Endocrine Society emphasize IV fluids plus arm-assisted therapy as the backbone of malignancy-associated hypercalcemia management. Treatment is coordinated, sequential, and dynamic. Rapid correction prevents arrhythmia and neurologic compromise. Sustained suppression prevents relapse. And as clinical pharmacists, we ensure appropriate IV fluid rates, timely calcitonin initiation, bisphosphonate dosing accuracy, and vigilant electrolyte monitoring, transforming acute calcium toxicity into stabilized, safe physiologic balance. Role 21 entails hypocalcemia management. We do not treat a lab value alone. We restore physiologic calcium homeostasis. Hypocalcemia destabilizes neuromuscular, cardiac, and endocrine function. Tetany, paresthesia, Chvostek and Trousseau signs, seizures in severe cases, QT prolongation and arrhythmia. Etiology guides therapy. Vitamin D deficiency, post-thyroidectomy or parathyroidectomy, hyperparathyroidism, renal failure, medication-induced bisphosphonates, loop diuretics. Step 1. Severe or symptomatic hypercalcemia. IV calcium is mandatory. Calcium gluconate is preferred for central access, 1 to 2 grams IV over 10 to 20 minutes for acute correction. Continuous infusion may follow, 0.5 to 1.5 milligrams per kilogram per hour titrated to ionized calcium. Calcium chloride is more potent, but requires peripheral caution. Cardiac monitoring is essential. Rapid infusion may provoke arrhythmia. Magnesium must be corrected if low. Magnesium deficiency impairs PTH secretion and calcium response. Step 2. Chronic or mild hypercalcemia. Administer oral calcium supplementation, 1 to 2 grams elemental daily in divided doses. Calcitriol or active vitamin D analogs are dosed at 0.25 to 0.5 micrograms daily, titrated to maintain corrected calcium in low normal range. Monitoring entails serum total and ionized calcium, phosphate, magnesium, and creatinine. Monitoring frequency is daily during acute therapy, then weekly until stable. Avoid overcorrection. Hypercalcemia carries arrhythmia and nephrolithiasis risk. Step 3. Identify and address underlying cause. Postoperative hypoparathyroidism, anticipate therapy immediately. In the case of vitamin D deficiency, replenish vitamin D stores. In the case of renal insufficiency, adjust calcium and vitamin D dosing. If it is medication-induced, hold offending agent if possible. Step 4 entails patient education. Teach them to do the following. Recognize tingling, cramps, or perioral numbness. Number 2, adhere to oral supplementation schedule. Number 3, maintain dietary calcium intake. And lastly, number 4, avoid abrupt discontinuation of therapy. Chronic therapy requires periodic re-evaluation of the following: calcium, phosphate, magnesium, vitamin D levels, renal function, signs of over or under replacement. Guidance from the Endocrine Society supports IV calcium for acute symptomatic hypocalcemia and oral calcium plus calcitriol for maintenance therapy. Hypocalcemia management is a balance between urgency and precision. Rapid IV correction prevents tetany and cardiac instability. Chronic therapy restores long-term skeletal and metabolic stability. And as clinical pharmacists, we ensure correct IV dosing, safe infusion rates, oral supplementation optimization, and ongoing monitoring, transforming potentially life-threatening calcium deficiency into stable, safe physiologic homeostasis. Role 22 entails dyslipidemia management. We do not treat cholesterol numbers alone. We reduce atherosclerotic cardiovascular risk. Dyslipidemia drives endothelial dysfunction, plaque formation, inflammation, and thrombosis. Primary prevention and secondary prevention require distinct intensity strategies. High-intensity statins are first line for patients with established ASCVD or high-risk profiles. Examples include atorvastatin 40 to 80 milligrams daily or rosuvastatin 20 to 40 milligrams daily. The goal is to achieve equal to or greater than 50% LDL-C reduction. Baseline labs are essential: fasting lipid panel, liver function tests such as ALT and AST, creatine kinase CK if muscle symptoms exist. Titration is guided by LDL-C response at 6 to 12 weeks. CK elevation is usually mild. Symptomatic myopathy requires dose adjustment or discontinuation. Hepatotoxicity is rare but serious. Monitor LFTs periodically. Discontinue if ALT is greater than 3 times ULN with symptoms. Adherence is critical. Statins are preventive. Benefit accrues over years. Drug-drug interactions must be reviewed. CYP3A4 inhibitors, e.g. clarithromycin, azole antifungals, increase statin levels. The risk of myopathy rises. In statin-intolerant patients, consider dose reduction, alternate day dosing, or non-statin therapy. Ezetimibe inhibits cholesterol absorption. PCSK9 inhibitors offer potent LDL reduction in resistant cases. Lifestyle modification remains foundational. Mediterranean or DASH dietary patterns, saturated fat restriction, regular physical activity, weight optimization, smoking cessation. Triglycerides above 500 milligrams per deciliter require additional attention. Fibrates, omega-3 fatty acids, or niacin may be indicated to prevent pancreatitis. Periodic monitoring includes lipid panel every 6 to 12 weeks during titration, then every 3 to 12 months once stable. Guidance from the American College of Cardiology emphasizes high-intensity statin therapy for secondary prevention and risk-based titration in primary prevention. Dyslipidemia management is proactive vascular protection. We combine pharmacotherapy, lifestyle, and ongoing monitoring. We anticipate adverse effects. We individualize therapy intensity. And as clinical pharmacists, we ensure appropriate statin selection, dose optimization, laboratory surveillance, and patient counseling, transforming chronic cholesterol elevation into durable cardiovascular risk reduction. Role 23 entails obesity pharmacotherapy. We do not treat body weight numbers alone. We reduce metabolic risk, improve cardiometabolic health, and support sustainable weight loss. Obesity drives insulin resistance, hypertension, dyslipidemia, and cardiovascular disease. Adipose tissue is hormonally active, promoting inflammation and endothelial dysfunction. Lifestyle therapy is foundational: caloric restriction, increased physical activity, behavioral modification. Pharmacotherapy is adjunctive, reserved for BMI equal to or above 30 or equal to or above 27 with comorbidities. Step 1. GLP-1 receptor agonists, semaglutide or liraglutide. They mimic endogenous incretins. Examples include semaglutide and liraglutide. They mimic endogenous incretins. They also reduce appetite, delay gastric emptying, enhance satiety. Start low. Semaglutide 0.25 milligrams subcutaneously weekly. Titrate every 4 weeks to 2.4 milligrams weekly. Monitor gastrointestinal tolerance. Nausea, vomiting, constipation are common early. Gradual titration improves adherence. Glycemic effects are significant in patients with diabetes mellitus. Monitor blood glucose or A1C. Step 2 entails the use of orlistat. It is a pancreatic lipase inhibitor. It reduces fat absorption by approximately 30%. Dosing 120 milligrams orally 3 times daily with meals. Monitor for gastrointestinal adverse effects: steatorrhea, bloating, fat-soluble vitamin deficiency. Supplement vitamins A, D, E, K at separate times. Step 3 entails use of phentermine topiramate. This is a central appetite suppressant combination. Phentermine is a sympathomimetic amine. Topiramate is an anti-epileptic with weight loss properties. Start low, titrate slowly to balance efficacy and tolerability. Monitor blood pressure carefully. Sympathomimetic effect may exacerbate hypertension. Assess cognitive side effects from topiramate such as paresthesia, insomnia, or memory difficulty. Step 4 entails monitoring and follow-up. Weight trajectory every 4 to 12 weeks. Blood pressure at each visit. Glycemic parameters in patients with diabetes mellitus. Renal and hepatic function as indicated. Assess adherence and tolerance. Adjust therapy or switch agents if weight loss is less than 5% after 12 to 16 weeks at target dose. Step 5. Safety considerations. In the case of GLP-1 receptor antagonists, they include pancreatitis and gallbladder disease risk. Phentermine topiramate has a teratogenic risk. It is contraindicated in pregnancy. Orlistat can cause fat-soluble vitamin deficiency and GI intolerance. Guidance from the American Heart Association supports pharmacologic therapy as adjunct to lifestyle intervention and emphasizes monitoring cardiovascular and metabolic parameters. Obesity pharmacotherapy is precision metabolic management. We individualize therapy based on comorbidities, tolerance, and efficacy. We titrate gradually to maximize weight loss. We prevent adverse effects and support long-term adherence. And as clinical pharmacists, we ensure correct drug selection, dosing, monitoring, and patient counseling, transforming chronic adiposity into meaningful cardiometabolic risk reduction and sustainable lifestyle improvement. Role 24 entails gestational diabetes management. We do not treat numbers alone. We protect 2 lives simultaneously. Gestational diabetes is hyperglycemia first recognized during pregnancy. Maternal glucose crosses the placenta. Fetal hyperinsulinemia drives macrosomia, neonatal hypoglycemia, and long-term metabolic risk. Every glycemic target must be individualized. Fasting below 95 milligrams per deciliter. 1 hour postprandial below 140 milligrams per deciliter. 2 hour postprandial below 120 milligrams per deciliter. Lifestyle therapy is first line. It entails medical nutrition therapy. Number 2, carbohydrate distribution. And number 3, moderate physical activity. When lifestyle is insufficient, insulin is preferred. Step 1, insulin therapy. Rapid-acting analogs such as Lispro or Aspart are used for postprandial coverage. Basal insulin such as NPH or Detamir are used for fasting control. Start low and titrate weekly. Adjust based on self-monitoring. Fasting and 1 to 2 hour postprandial glucose. Hypoglycemia risk is heightened, especially overnight. Patient education on recognition and treatment is mandatory. Step 2, avoid teratogenic medications. ACE inhibitors and ARBs are contraindicated due to risk of fetal renal malformation. Statins are contraindicated due to risk of congenital malformations. Metformin and glyburide are sometimes used but require careful risk-benefit discussion. Step 3, monitoring. It requires frequent glucose checks, fasting and postprandial daily. A1C is less reliable in pregnancy due to physiologic changes. Maternal blood pressure, weight, and ketone monitoring inform therapy adjustment. Fetal surveillance entails the following. 1. Ultrasound for growth and amniotic fluid. And 2. Non-stress tests in 3rd trimester as indicated. Step 4. Delivery planning. Glycemic targets are tightened in the final weeks. Insulin adjustments is often needed intrapartum. IV insulin infusion may be required during labor. Postpartum, insulin requirements drop abruptly. Risk of hypoglycemia increases. Reevaluate glucose homeostasis at 24 to 72 hours postpartum. Breastfeeding considerations include the following. Insulin and most analogs are safe. Avoid secretory drugs with known lactation risk. Step 5. Long-term follow-up. Women with gestational diabetes have elevated lifetime risk of type 2 diabetes mellitus. Annual glucose screening is recommended. Lifestyle counseling is reinforced. Guidance from the American Diabetes Association emphasizes insulin as the standard of care for inadequate lifestyle control, and strict avoidance of teratogenic medications. Gestational diabetes management is precision dual patient therapy. We balance maternal and fetal safety. We titrate insulin carefully. We avoid harmful agents. We monitor vigilantly. And as clinical pharmacists, we ensure correct insulin selection, dosing, monitoring, and patient education, transforming gestational hypoglycemia into optimized maternal-fetal outcomes. Role 25 entails pediatric endocrine dosing. We do not treat numbers alone. We support growth, development, and lifelong metabolic health. Children with endocrine disorders are not small adults. Physiology is dynamic. Metabolism is variable. Hormonal surges drive growth and puberty. Precision is mandatory. Step 1 entails weight-based dosing. Insulin dose is calculated per kilogram of body weight. Typical starting doses are as follows. In the case of type 1 diabetes mellitus, 0.5 to 1 unit per kilogram per day. It is divided into basal and bolus regimens. Adjustments are frequent. Growth spurts increase insulin requirements. Illness or reduced intake may lower needs. Other endocrine medications, e.g. thyroid, hydrocortisone, growth hormone, also require weight or BSA-based dosings. Step 2 entails growth monitoring. Height velocity every 3 to 6 months. Weight trajectory tracked at each visit. BMI percentile and Z-scores contextualize metabolic status. Pubertal staging TANA is essential. Hormonal therapies may alter timing and tempo. Step 3 entails safety monitoring. Hypoglycemia is particularly dangerous. Children have less predictable feeding and activity patterns. Education for families on recognition and treatment is critical. Long-term endocrine therapy may impact bone health, lipid profile, and cardiovascular risk. Regular labs include A1C, electrolytes, liver function, thyroid, IGF-1, or other relevant markers. Step 4 entails individualization. Dose adjustments must account for age, weight changes, pubertal stage, activity level, concurrent illness. Psychosocial factors influence adherence. Family engagement improves outcomes. Step 5 entails longitudinal assessment. Endocrine therapy in children is iterative. Monitor metabolic control. Monitor linear growth. Monitor pubertal progression. Adjust therapy proactively to avoid over or under replacement. Guidance from the Pediatric Endocrine Society emphasizes weight or BSA-based dosing, frequent monitoring, and growth-informed adjustments. Pediatric endocrine management is dynamic physiologic support. We balance metabolic control with normal growth and development. We anticipate rapid physiologic changes. We prevent long-term complications. And as clinical pharmacists, we ensure accurate weight-based calculations, monitor adherence, track growth and pubertal milestones, and educate families, transforming pediatric endocrine therapy into safe, precise, and growth-compatible metabolic management. Role 26 entails geriatric endocrine care. We do not treat numbers alone. We treat functional independence, quality of life, and safety. Older adults exhibit unique physiology, reduced renal clearance, impaired hepatic metabolism, blunted counter-regulatory responses. Polypharmacy increases adverse event risk. Step 1. Glycemic targets. A1C goals must be liberalized. For frail adults, multiple comorbidities, or limited life expectancy. Target A1C 8 to 8.5%. Hypoglycemia carries disproportionate risk, including the following: falls, fractures, arrhythmias, and cognitive decline. Avoid regimens prone to severe hypoglycemia. Sulfonylureas with long half-lives. High-dose insulin without frequent monitoring. Time in range, i.e. 70 to 180 milligrams per deciliter, remains valuable. But priorities shift towards safety and stability. Step 2 entails medication selection. We prefer agents with low hypoglycemia risk, such as metformin if renal function permits. DPP-4 inhibitors. SGLT2 inhibitors monitor volume status and renal function. GLP-1 receptor antagonists for weight or cardiovascular benefit, if tolerated. Renally cleared drugs require dose adjustments. Polypharmacy interactions must be reviewed meticulously. Step 3 entails monitoring and functional assessment. It includes regular review of cognitive status, frailty indices, and fall risk. Adjust therapy based on functional goals, not solely lab values. Hypoglycemia risk score guides regimen selection. Blood pressure, renal function, and electrolytes are monitored regularly. Step 4 entails individualization and shared decision-making. Consider life expectancy, comorbidity burden, and patient priorities. Engage patients and caregivers in target-setting discussions. Emphasize simplicity of regimens to improve adherence and reduce errors. Step 5 involves broader endocrine considerations. Thyroid, adrenal, and bone health may influence glycemic stability and medication choice. Polypharmacy review can reduce drug-drug interactions that exacerbate endocrine risk. Guidance from the American Geriatric Society emphasizes individualized targets, hypoglycemia avoidance, and function-centered care. Geriatric endocrine management is precision risk mitigation. We balance metabolic control with safety, cognitive function, and quality of life. We prioritize hypo over hyperglycemia prevention. We integrate comorbidities and physiologic aging into every decision. And as clinical pharmacists, we optimize medication selection, adjust doses, monitor labs, and counsel patients and caregivers, transforming complex endocrine therapy into safe, functional, patient-centered care in older adults. Role 27 entails multidisciplinary rounds participation. We do not operate in silos. We integrate expertise to optimize endocrine care. Complex metabolic and hormonal disorders demand coordinated oversight. Medication adjustments, nutrition, education, and monitoring intersect. Step 1 entails collaborative engagement. Rounds include endocrinologists, diagnostic precision, therapeutic strategy, nurses, bedside monitoring, patient education, and drug administration. Dietitians, individualized nutrition plans, and glycemic load management. Diabetes educators, self-management, adherence, lifestyle coaching. Clinical pharmacists provide pharmacologic expertise, dosing precision, and adverse effect mitigation. Step 2 entails data-driven discussion. Review laboratory trends including glucose, electrolytes, and hormone levels. Evaluate CGM downloads, insulin logs, and adherence patterns. Integrate comorbidity impact, renal, hepatic, and cardiovascular. Recommendations are evidence-based and patient-centered. Prioritize safety, efficacy, and functional outcomes. Step 3 entails medication optimization. Identify drug-drug and drug-disease interactions. Adjust insulin, oral antidiabetics, or endocrine therapies collaboratively. Anticipate transitions of care, ICU to ward, inpatient to outpatient. Facilitate reconciliation to prevent duplication, omissions, or dosing errors. Step 4 entails patient-centered communication. Rounds reinforce shared decision-making. Educate patients in real time with multidisciplinary input. Engage caregivers in therapy planning, adherence strategies, and monitoring responsibilities. Step 5, system-level quality and safety. Multidisciplinary participation reduces adverse events, standardizes protocols for glycemic control, steroid management, and endocrine emergencies, improves continuity across care settings. Documentation of recommendations ensures clarity and accountability. Metrics such as hypoglycemia rates, medication errors, and patient satisfaction are tracked. Guidance from the Society for Hospital Pharmacists underscores multidisciplinary rounds as a cornerstone of safe, effective endocrine management. Participation is not passive. It is active, iterative, and collaborative. We identify risks, we optimize therapy. We educate the team and patient. We align interventions across disciplines. And as clinical pharmacists, we operationalize pharmacologic expertise in real time, ensuring every recommendation balances efficacy, safety, and continuity of care, transforming complex endocrine management into coordinated, high-value, patient-centered outcomes. Role 28 entails medication reconciliation. We do not merely review lists. We prevent harm and optimize endocrine outcomes. Polypharmacy is common in complex endocrine patients. Multiple prescribers, hospitalizations, and comorbidities increase risk of duplication, omission, or adverse interactions. Step 1 entails comprehensive review. Collect complete medication history, prescription, over-the-counter, supplements, and herbal products. Verify doses, frequency, route, and indication. Assess adherence and patient understanding. Step 2, identify endocrine-specific risks. Let's look at medications that impact endocrine function. Amiodarone causes thyroid dysfunction, hypo or hyperthyroidism. Glucocorticoids cause hyperglycemia and osteoporosis. Thiazides cause hypercalcemia and glucose elevation. SGLT2 inhibitors cause euglycemic DKA risk during acute illness. Lithium causes hypothyroidism or nephrogenic diabetes insipidus. Evaluate cumulative effects and potential drug-drug interactions. Step 3, detect duplication and contraindications. Avoid multiple drugs with overlapping mechanisms, e.g., dual sulfonylureas. Identify therapy conflicts, ACE inhibitor plus potassium-sparing diuretic in renal impairment. Adjust therapy to minimize risk while maintaining efficacy. Step 4, communication and documentation. Collaborate with physicians, nurses, and pharmacists to update the active medication list. Provide clear recommendations for discontinuation, substitution, or dose adjustment. Document rationale for changes in the medical record to ensure continuity across care transitions. Step 5, patient education. Explain purpose, dosing, timing, and potential adverse effects. Highlight endocrine-specific warnings. When to monitor blood glucose, thyroid function, or electrolytes. Red flag symptoms warranting urgent attention. Step 6, monitoring follow-up. Ensure laboratory surveillance aligns with adjustments. Perform thyroid function tests after amiodarone initiation. Monitor serum calcium for loop thiazide therapy. Monitor renal function and electrolytes for ACE inhibitors, SGLT2 inhibitors, or diuretics. Guidance from the American Society of Health System Pharmacists emphasizes structured medication reconciliation as critical to safe endocrine care. Medication reconciliation is proactive, preventive, and patient-centered. We detect interactions, prevent duplication, and reduce adverse events. We optimize therapy while safeguarding physiologic homeostasis. And as clinical pharmacists, we systematically review, reconcile, and educate, transforming a complex medication regimen into a safe, coordinated, and evidence-based endocrine management plan. Role 29 entails development of institutional protocols. We do not rely on ad hoc decisions. We standardize care to reduce variability, prevent errors, and optimize outcomes. Endocrine emergencies and complex therapies demand clear, evidence-based protocols. Step 1. Insulin infusion order sets. Develop structured IV insulin algorithms for critical care and perioperative patients. Specify the following. 1. Initial dosing based on weight or insulin sensitivity. 2. Titration parameters tied to hourly glucose measurements. 3. Safety limits for hypoglycemia prevention. 4. Transition guidance to subcutaneous insulin. Embed standardized monitoring, which entails doing the following. First, integrate protocols into daily practice. 1. Hourly glucose checks. 2. Electrolyte and potassium monitoring. 3. Renal function assessment. Step 2. Diabetic ketoacidosis (DKA) pathways. Define stepwise management. 1. Fluid resuscitation strategy based on volume status. 2. Electrolyte correction, e.g. potassium or phosphate. 3. IV insulin titration and transition to subcutaneous therapy. 4. Criteria for ICU versus ward management. Include clear triggers for escalation and de-escalation. Integrate multidisciplinary roles: physicians, nurses, pharmacists, and dietitians. Step 3. Hypoglycemia bundles. Establish rapid response protocols for inpatient hypoglycemia. Specify the following. 1. Recognition thresholds, e.g. below 70 mg per deciliter, below 54 mg per deciliter. 2. Immediate treatment steps: oral glucose, IV dextrose, and glucagon. 3. Reassessment and monitoring frequency. 4. Documentation and root cause analysis. Step 4. Integration with electronic health records. Embed order sets, alerts, and clinical decision support. Ensure automatic reminders for monitoring labs, dose adjustments, and re-evaluations. Step 5. Education and compliance. Train staff on protocol rationale, execution, and safety checks. Audit adherence regularly. Update protocols based on new evidence, outcomes data, and safety reports. Guidance from the Society for Critical Care Medicine and Endocrine Society supports standardized insulin, DKA, and hypoglycemia pathways to improve patient safety and metabolic control. Protocol development is proactive, evidence-driven, and safety-focused. We reduce errors. We optimize therapy. We improve consistency across care teams. And as clinical pharmacists, we design, validate, implement, and educate on these protocols, transforming complex endocrine management into streamlined, high-reliability institutional practice. Role 30 entails patient and staff education. We do not teach information alone. We build competence, confidence, and safe self-management. Endocrine care is only as effective as adherence and understanding. Patients and staff must grasp both physiologic rationale and practical execution. Step 1. Structured insulin injection training. Demonstrate proper technique. Correct site selection and rotation. Pay attention to needle length, angle, and injection depth. Pay attention to timing relative to meals and blood glucose readings. Review storage, handling, and expiration of insulin. Practice sessions with supervision improve retention and confidence. Step 2. Self-monitoring of blood glucose, SMBG education. Teach frequency based on regimen. Multiple daily injections or insulin pumps require pre-meal, bedtime, and sometimes overnight checks. Emphasize log maintenance and trend recognition. Interpret readings to guide carbohydrate intake, correction doses, and exercise planning. Include guidance on CGM use, alarm management, and data download interpretation. Step 3. Lifestyle counseling. Address nutrition, physical activity, and behavioral strategies. Tailor carbohydrate intake to cultural and individual preferences. Highlight exercise timing, hydration, and safety precautions in diabetes mellitus or endocrine disorders. Discuss sleep, stress, and medication adherence as part of holistic metabolic control. Step 4. Staff in-service sessions. Regular training for nurses, dietitians, and allied health professionals entails the following. 1. Insulin protocols, pump management, and hypoglycemia recognition. 2. Interpretation of glucose trends and lab results. 3. Emergency response for DKA, hyperglycemia, and hypoglycemia. 4. Updates on new medications, devices, or institutional protocols. Simulation and case-based learning reinforce practical skills. Step 5. Ongoing reinforcement and evaluation. Assess understanding through teach-back methods. Audit adherence to insulin technique, SMBG, and dietary recommendations. Provide refresher sessions and update staff on evidence-based guidelines. Guidance from the American Diabetes Association underscores structured patient and staff education as central to safety, adherence, and metabolic outcomes. Education is not episodic, it is continuous, interactive, and personalized. We prevent errors. We improve glycemic control. We empower patients and staff. And as clinical pharmacists, we design, deliver, and evaluate educational interventions, transforming complex endocrine therapy into confident, competent, and safe patient-centered practice. If this conversation challenged your thinking, then we've done our job. Because endocrinology is no longer about glucose control alone, it is about precision. It is about risk orchestration. It is about preventing tomorrow's complications today. If you are serious about advancing endocrine pharmacotherapy, if you believe clinical pharmacists belong at the highest decision-making tables, then this channel is built for you. The science is evolving. Guidelines are shifting. Therapies are expanding. And those who stay ahead will lead. So here's what I need you to do right now. Like this video, so more endocrine specialists can find it. Subscribe, because the next session goes even deeper. Hit the notification bell so you never miss advanced updates. Share this widely with your endocrinology colleagues, fellows, residents, and pharmacy specialists across the globe. And most importantly, comment below. Tell me, which endocrine challenge should we dissect next? DKA transitions? Advanced CGM analytics? Thyroid storm controversies? GLP-1 cardiovascular positioning? Your comments shape the next masterclass. This is not basic medicine. This is specialist-level endocrine strategy. And together, we elevate practice, we refine pharmacotherapy, and we redefine multidisciplinary excellence. Stay precise, stay evidence-driven, and stay ahead. I'll see you in the next video.